Hi, everyone, and welcome to the Faculty Fridays Research Seminar Series. My name is Anne-Marie Parker, and I'm a research associate at the Joplin campus of KCU to Dr. Staudinger. Today, I'll be introducing Dr. Sharon Gordon, who will be presenting for today's talk. I ask that everyone please stay muted for the presentation and save your questions for the end. Now, to introduce our speaker, Dr. Sharon Gordon earned her dental degree from the University of Texas Health Science Center at San Antonio and completed a 2-year general practice residency program at the Medical Center Hospital in San Antonio prior to joining the National Institute of Health as a postdoctoral fellow. While at the NIH, she earned an MPH in epidemiology and a PhD in clinical investigation, both from Johns Hopkins University. During her 13-year career at the NIH, she conducted clinical research and treated medically complex patients at the NIH Clinical Center and directed the intramural and extramural educational programs at the National Institute of Dental and Craniofacial Research, NIH. Her research centers on the mechanisms of pain and analgesia with an emphasis on clinical and population-based research, for which she was honored with the Distinguished Scientist Award from the Pharmacology, Toxicology, and Therapeutics Group of the International Association for Dental Research Award. Over the past several years, her work has evolved to the evidential basis of pain management, highlighting diagnosis and treatment of acute and chronic facial pain, forming a basis for the continuing education she presents. Today, she's going to be talking to us about reducing mucositis and its correlation to head and neck cancer.
Thank you. I do want to say, contrary to the instructions, because I like to do that sometimes, if you really have a question and you want to jump in, I would rather you go ahead and ask the question at the time so we can have more of a discussion and dialogue rather than saving them to the end, if that's okay with you.
No, that's perfect. It's your presentation.
Thank you. And thank you for the kind introduction, which I wrote myself. I want to say that I have no conflicts to declare with today's presentation, but I will disclose that I was site PI for the phase 2 study, and the sponsor is Galera. Some of the slides I will show are their slides, and they're publicly available online if you search for Galera. So mucositis, which translated means inflammation of the mucosa, is an oral complication of cancer therapy. It's actually a very much broader term than that, but today we're going to focus on complications of cancer therapies. And to some degree, almost all cancer therapies, if they're immunosuppressive, will create some inflammation of the lining of the alimentary tract. So just keep in mind, even though I'm focusing on the oral cavity today, that the mucosa and the alimentary tract starts at the mouth and it goes all the way down. And generally, mucositis can present along any part of that tract, and depending on the age, it may manifest in some more than others. I also want to mention for any medical students who might be in the audience that head and neck cancers account for 4% of all cancer types. So it's a fairly frequent cancer that you would encounter, and recognition of mucositis as one of the consequences is important for your practice. So as I mentioned, oral head and neck cancers are common, and oral mucositis is the most common side effect of chemoradiation treatment. So that's chemotherapy plus radiation. So although I mentioned that mucositis will manifest with most immunosuppressive therapies, it is much more common when radiation is added to the regimen along with chemotherapy. The painful inflammation and ulceration of the mucous membranes lining the mouth, it can also attack the gums, the tongue, and the throat. And it's been fairly well prescribed in terms of its onset and duration with the onset of therapy, and affects almost all patients who are treated with chemorads whenever it's focused on the area of the head and neck. About an 85% incidence of the severe mucositis category, which is the WHO grades 3 and 4, which we'll talk a little bit about later. Currently, there's no intervention approved for chemo and radiation. There is one approved agent for mucositis on the market called palifermin, and it is a keratocenic growth factor that is approved for the use of mucositis caused by treatment of hematologic cancers. So it is an open market and a vast need, as I hope that you will come to understand by the end of this presentation. So in patients who are receiving radiation to the head and neck, the incidence of mucositis is about 100%. In transplant patients, it's approximately 90%, and 40% in patients with chemotherapy alone. It affects the quality of life for these patients undergoing these therapies for many reasons, which we'll talk about in the clinical manifestations. It has significant economic consequences and it's clinically devastating for patients and for their families. This slide is summarizing the impact of oral mucositis, and the citation that you see here at the bottom of the slide will give an overview. It's basically a review of oral mucositis that was published in 2019. So this gives you an overview of the numbers of patients with head and neck cancer in the US per year. Of those, 65% are receiving a fractionated dose of radiation, and usually along with cisplatin as the chemotherapeutic agent. And 70% of these patients will get severe oral mucositis, which means they really can't eat. And I'll just draw your attention here, if you can see my cursor, to the WHO grading scale for mucositis. So the severe category is in the yellow and the red here. 20 to 30% can reach the grade of 4. They're not able to eat or drink at all. And as was mentioned, there is no approved drug for this particular therapy or indication. Here's just summarized some of the problems that we'll talk about just a little bit more, go more in depth. And in another slide, we'll visit which treatments actually have some evidence behind them at this point. So economically, the impact in a study that was looked at claims data over a 6-month period, and in patients with and without oral mucositis, but receiving chemoradiation for the same head and neck cancers, which is usually a squamous cell type. You can see that there's a difference in the patients that have oral mucositis and the patients who don't get oral mucositis. And it adds up to an average of $32,000 in differential medical expenses within the first 6 months of starting radiation therapy. So it's a significant economic impact. Just my personal experience, and I'm sure Dr. Abbott can chime into this as well. Many of the patients undergoing these therapies they're not insured or they're underinsured. As you may or may not know, but you'll hopefully come to realize as you get to know us at the College of Dental Medicine a little bit more, many things involving the oral cavity are not covered by medical insurance. So many times patients are underinsured or not insured, and these costs accumulate for them. So clinically, whenever there's an oral mucositis affecting to the degree that we talked about, where patients have severe pain, they can't eat, what can happen is that there has to be treatment modifications in their cancer therapy regimen. So that can mean they have to have a reduced dose, a treatment interruption, like they call it a holiday, or a regimen alteration where, say, they may continue the chemo and stop the radiation until the patient can recover just a little bit. So as you can imagine, that has severe consequences for the patient's treatment of their cancer. And of course, treatment of the cancer is the primary aim. So whenever you have a complication that significantly impacts the ability to treat the cancer, that's a big problem. It also results in rehospitalization and increased length of stay. So it's not uncommon that in between the 5th and 7th week of radiation therapy, that patients who get to the severe stage of oral mucositis have to be hospitalized. Many times that's so that they can receive parenteral nutrition or TPN. so that they can get IV opioids and for the ability to control their sepsis. So they may have to have antibiotics, intravenous antibiotics. And if they didn't have a feeding tube placed at the beginning of their therapy, their eating and nutrition is severely compromised. Airway compromise can happen where they might not be able to swallow or breathe. And as I mentioned, sepsis by the opportunistic infections that can take hold of the compromised barrier whenever you have open ulceration in the oral cavity. This slide is just to remind me to speak about the most commonly used topical treatment or approach for mucositis, and that's called magic mouthwash. If you've heard of it or not heard of it, it's depicted here with a wizard because magic mouthwash is really one of those hocus pocus kind of treatments. And I say that because depending on which hospital you are in, the ingredients will vary by hospital. It's something that's formulated by the pharmacy. It's not something that you purchase or has been approved by the FDA, for the ingredients and the amounts of ingredients that are contained within it. And it's been used for a very long time without good evidence, but it's one of the empiric approaches to treatment that everybody gives. They give magic mouthwash. And there's many other agents that have been tried as therapies for mucositis, which have not borne the test of time under evidence. Essentially, many different things have been tried, and I'll just summarize the evidence that's most currently published in this publication here on the lower left part of the screen or your lower right. So of the different agents that have been reviewed for evidence, basic oral care, which means keeping oral hygiene, so a clean mouth, which minimizes the microbial burden and then minimizes the chance for inflammation and opportunistic infection whenever the person becomes immunosuppressed. So there's good evidence for that, which means, a good cleaning before the patient undergoes their regimen, removal of any diseased teeth or issues that could lead to an infection once they're immunosuppressed. So even though it varies, the protocols vary by hospital, it's very optimal for you as a physician to have a dental consult prior to having the patient undergo their immunosuppressive regimen so that those issues can be dealt with in a preventive manner. Then there's also fairly good evidence for antimicrobials that might be topically applied, agents that coat the oral cavity that minimize the entry of microbes through the barrier of the epithelium, which has been compromised. And then anesthetics and analgesics, such as a morphine type of mouthwash. So notice that that's not magic mouthwash. That's like you basically take morphine and or mix it with lidocaine and you have a compounded mouthwash that's created in the hospital for patients to swish and spit. The other types of things that have been looked at, like other anti-inflammatories, laser light, the jury is out on those. There's not sufficient evidence to say that those are effective. For a long time, we believed, based on like a small study that had been published, that cryotherapy or use of ice chips was effective, but in additional studies that has not borne out to be true. And then other types of agents, like you might hear about curcumin or honey from, white honey from honeybees in Georgia, or things like that, have not shown sufficient evidence to be effective. So what we have right now is, even though these are effective, these are pretty much palliative. They're to have comfort care for the pain. They're to coat the oral cavity to minimize bacterial entrance into the bloodstream. We don't really have any agents that are effective for the mucositis itself. And we'll talk a little bit about what the therapy that I'm going to present to you today, the experimental therapy, is and what's the mechanism of action. So this slide just represents, we've been talking about mouthwash and barrier agents, things that are topical. The perception in a study that was done asking physicians what they thought the perception was and what they thought the most important treatment outcome would be. The most important outcome was to prevent or reduce the incidence of the grade 3 or 4 oral mucositis with an acceptable safety profile, minimal tumor interference, which we'll talk about a little bit more, reducing the time or duration of the mucositis. So not just preventing it, but at least minimizing the number of days or delaying its onset, and able to be given to a variety of people and easy to administer. This is probably one reason why magic mouthwash has persisted in use, because it doesn't necessarily do these things, but it's easy to administer and it provides some comfort, and it seems to be innocuous in terms of side effects. So if we were really wanting to target a therapy for mucositis, there's been a model that's proposed by Steve Sonis, who is pretty much the godfather of oral mucositis. The limitations of previous research have been due to have led to the lack of available therapies. And a lot of the work has focused on growth factors. So I mentioned palifermin as a KGF entity. So it was originally thought, and this slide just depicts the pathogenesis, the 5 steps of mucositis. So you've got initiation, upregulation, a signal amplification, ulceration, and healing. So the previous thought, the dogma was, we know that cancer therapies of all types and those that cause mucositis, they're attacking rapidly dividing cells. And that's one reason why you get a mucositis, because epithelium turns over and reproduces more quickly than most other of the types of epithelium in the rest of our body. So the thought was, if we can boost the growth factors, then we can heal faster. And whenever you get this part of the ulceration, you're going to get a quicker healing. And that was the basis of palifermin. One of the issues, though, with that, and I mentioned one of the therapeutic outcomes that you want to have is you want to the cancer to be cured. And so one of the issues with growth factors is, could they potentially help the tumor to grow instead of impeding its growth? And therefore, if you're treating the symptom, you're actually helping the tumor and the cancer to win. And so that's been one of the big issues with this type of research, because your overall therapeutic goal is to defeat the cancer and then minimize the adverse effects of everything else that's going on. So this model is based on a reactive oxygen species generation. During environmental stress, reactive oxygen species increases, and that's called oxidative stress. And there's certain other types of molecules, superoxide dismutase, which is a class of enzymes that catalyzes the dismutation of that superoxide into oxygen and hydrogen peroxide. So these are now being investigated, and I know Dr. Staudinger is aware of this, and many other conditions as a sort of antioxidant defense mechanism, and they're showing a lot of promise. So I'll just go through the pathogenesis of the mucositis. And remember, when you're looking for a therapy, you want to look at the mechanism of action of the condition so that you can target a therapy towards minimizing those issues. So here you see the radiation will cause oxidative stress to the cells. The chemotherapy, and it does that from the exterior because the beam is coming in from outside the body. The chemotherapy, those agents are coming through systemically. So they're attacking from within, the radiation is coming from without. You're generating a reactive oxygen species, and that results in damage to the cells. And then it starts the signaling and the upregulation of other things that cause cell death. So you can see like NF-kappa B, your interleukins, your TNF alpha. These lead to apoptosis, cell injury, and death. And this is a very oversimplified pathway, I will say. And again, they attack the mucosal tissues preferentially because they are rapidly dividing, and their processes are accelerated compared to other parts of our body. Once you have the cell death, of course, and even before then, these signals also talk to our inflammatory cells. So our macrophages and our T cells come in, they want to fight the battle. They start releasing other types of inflammatory agents, which have a bystander effect on your innocent cells and causing them injury, in addition to where they think they're attacking their invaders. At this point, when you have enough apoptosis, then you start to get necrosis and you start to have an ulcer or in a breach in your defense mechanism. And then you get your bacterial colonization. And then there can be an opportunistic infections can lead to sepsis. That just makes your macrophages go more crazy because they want to fight the bacterial invasion, and you get more bystander effect by the signaling cytokine amplification, which leads to overt inflammation that should lead to resolution if it can be interrupted. And then eventually, when you stop the insult, then you'll get healing. If you didn't ever stop the radiation, I just don't think you would ever get healing because that insult just continues. And that's through your extracellular matrix signaling. That's where your epithelial and your keratinocytic and your other growth factors can be helpful. But it's a little too late at that point, and that's why palifermin is actually not that good. And so that's the process essentially. So the insult or the radiation causing the superoxide is demonstrated on this slide here. And as I mentioned, it leads to injury, the oxidative stress, it interferes with other issues like mitochondrial respiration. And if you can interfere with that process, then perhaps you can target where all the damage is happening. And that's where the dismutase mimetics are coming in. And Galera has one of these that they're pursuing for a variety of indications, but primarily mucositis. So how does that work? We know that we generate our own superoxide dismutase enzymes. However, we can't necessarily generate enough of them. And one of the issues is size, molecular size. So this particular entity, molecular entity under study is called a vasopossum, and it's supposed to shift the balance in normal and abnormal processes within the cells, shifting it towards a more favorable healing balance, which would happen in the setting of inflammation naturally with an intact host. So their dismutase mimetics are taking the native enzymes, and they are actually introducing small molecules that would actually come in and add to that. So if you think about like an antibiotic, your body will naturally, if you have an attacked immune system, your body will naturally fight off a bacterial infection. But when it becomes overwhelmed, it needs help. And that's where antibiotics come in. This is a similar concept where your body would be able to heal itself and fight off the reactive oxygen species damage, but it needs help because you're immunosuppressed. So this is basically adding in that help. So now I'm going to describe to you the phase 2 study, which is published and this is actually the protocol name here. I'll give you the publication in just a moment. It took this molecular entity at a high dose, we call the high dose, 90 milligrams, 30 milligrams, which was a low dose, or placebo, so 3 groups. And it was an IV infusion over an hour prior to, within 60 minutes of receiving your radiation therapy. So subjects would come in, prior to the radiation appointment, have the infusion, and then go to the radiation appointment. And the thought behind that was that you would want this circulating in the bloodstream before you have the radiation insult. And if I can just go back a little bit, when you have radiation therapy, you have it every day for 7 weeks, usually not on the weekend. So it's 5 days a week over 7 weeks. Sometimes it could be give or take a week or so, depending if you took a break, et cetera. So that's a lot of insult. So the thought was, if you can load the body with these dismutase mimetics and then have your radiation appointment, then what would happen? The stratification factor was with or without HPV positive status on the biopsy of the tumor. And for those who wonder why that might be, because HPV is known to be a risk factor for head and neck cancers. And there are differences in outcomes for those who are HPV positive or negative on those types of tumors. And so we wanted to find out if that was going to make a difference in the response for these patients. And then your endpoints, primary endpoint was reduction in the median duration of severe oral mucositis, which is grade 3 or 4. Secondary outcome was reduction in the incidence, or even, that you would never get to 3 or 4 at the pre-specified time points. And exploratory endpoint was time to development of severe oral mucositis. And then lastly, a long-term outcome was tumor outcomes. So 2 years follow-up. Has your tumor, if you were in a different group, did that affect your tumor recurrence, coming back, metastasis, et cetera. And so here, as I mentioned, 7 weeks is the duration of the therapy, 3 groups, and there's the grading scale that we used for classifying mucositis, starting at the baseline before any therapy started. This is just summarizing the objectives. And I should not neglect to mention safety and tolerability, which is important in tumor growth and long-term follow-up. So the outcomes are shown here. 90 is in blue, 30 milligrams is in the orange, placebo is in the light gray. So for the incidence of severe mucositis through the whole 7 weeks, so through all of RT, you see that there was a significant reduction in the incidence at the highest dose, the 90 milligram dose. Similar with duration, that was the biggest impact. A 92% reduction in median days with severe oral mucositis, which when patients would be grading this or rating this as, what we call patient global, or what they value having fewer days of severe oral mucositis. And you can see that was also significant at the 90 milligram dose. And then severity, a 47% reduction in the incidence of grade 4 oral mucositis. And this is the publication, if you would like to take a look at it. I think that this graphic visually is a good representation of the high dose versus placebo. If you think about the fact that the low dose and placebo didn't really separate out that much, this is depicting the difference between essentially the efficacious dose and placebo. And you can just tell by looking at the red, which is the grade 4, there's much fewer red bars on the 90 milligram dose than compared to placebo. I like those visual representations. And then in terms of safety, these grades are actually not mucositis grades. These are other types of grading that you do for adverse effects. So here you can see, when compiled together, all of the different safety parameters, that the 90 milligrams did better, or approximately the same, sorry, that you really couldn't separate out any of the doses from a placebo in terms of number of AEs. And the reason that is because the majority of AEs were really attributed to the chemotherapy and radiation regimen itself. So this is typical in studies where the majority of problems are due to the cancer therapy, which is extremely toxic. So this is not a surprise. What's important, though, is really the next one. This is the only time I've seen this result, and I will say that I've done a lot of mucositis studies. Most of them don't go very far. This one, I think, is going to go all the way to approval because the outcomes are really good. So the important thing that, is worrisome is it going to make the cancer worse? If so, then there's really no excuse to use any kind of agent because your primary goal is to cure the cancer. So here at 2 years, there's no differences in the groups in terms of survival, progression-free survival, which means the tumor didn't grow from the time that you finished your therapy, your local regional control, which is essentially more your local. So this would be by imaging. So looking at the tumor size, this is going to be by looking in the oral cavity, if something has returned, if there's any lesions that have returned, and then metastasis. So this is a very good outcome at 2 years. And the reason it's only 2 years, I know they'll follow it out at least 5, because that's usually how far out you go, is because the study just concluded in like 2018. So the publication came out in 2019. This was reported at the ASCO meeting last year. And prior to them starting their phase 3 study, which we'll talk a little bit about next. So the next steps, they had the robust response in phase 2, which gave an amazing efficacy signal. Typically, you're looking mainly for safety and tolerability. A great efficacy signal with a very small number. This is a relatively small number for a clinical trial with 3 arms. So that was an overwhelming response. And then this is just about toxicity and other types of things. These are other areas they're pursuing. They're looking at other types of cancers. And then phase 3 was started in 2020. We were starting to ramp up in 2019. And then, of course, the pandemic came. And so it kind of delayed the outcomes of this. I will say that the trials continued because you still have to treat people for cancer, no matter what whatever else is in the face of what's going on. But the majority of the enrollment was in Europe rather than the United States. And I think that's mainly an institutional type of scenario in terms of how we went on lockdown and things like that. So they're a little behind on completing this study. They're basically now just doing 90 milligrams versus placebo, drop the low dose. Same, everything else is the same, except they stratified on surgery because many patients, probably about half of the patients might have a surgery for debulking or whatever ahead of time. And so that's an important factor because you want to know, is there a difference in outcome if you did a surgery before you started your chemo rads, or is it the same? Same primary endpoints, maybe just a little bit of difference in tumor outcomes that they're going to be looking at, but everything's pretty much the same. They named it now. It's kind of like when you graduate from phase 2 to phase 3, you got to get a catchy name. So they gave a name to it, but it's the same molecular entity. So I will kind of give a little summary here. And then I don't think we have any medical students, do we, with us? This is our summary. So this is the most promising potential treatment for mucositis since the approval of palifermin. And palifermin's been the only anti-mucositis agent that's ever been approved by the FDA. When that happens, it's usually a low bar. So the first drug that gets approved may not be the most efficacious, but because it's compared to nothing and nothing's available, it usually gets approved. This is the only anti-mucositis agent that I've seen that has the potential to inhibit tumor growth, or at least not augment tumor growth. And as I mentioned, it's in phase 3 trials. So with that, I will take questions. Should I stop sharing, or should I
You're
keep
good.
it?
You keep it up if you would like.
Okay.
Whatever you want to do. But thank you for the presentation. That was great. I actually have a question.
Sure.
If
Go
nobody
for it.
else does. So I read the suggested reading that went along with this study. And one of the questions I had was, I saw a part in here where it says that the other concurrent available or experimental topical devices or things were excluded. And so I think that was the like the antimicrobials, the coating agents, the anesthesia. Do you think if you did that with what you did in the study together, that it would be even better, or would you see no change? Just what do you think, I guess?
Yeah, thanks for bringing that up, because those exclusions were potentially sticky because people are afraid to not do something even though there's no evidence, because they feel like it's standard of care. So I would never meet a physician who would not give magic mouthwash because they would be afraid not to give it, even though there's no evidence. So the excluded agents were intended not to, you don't want to obscure the signal, right? So if your main outcome is your WHO scale, and that's not the best scale, but it's the one everybody uses. The problem with it is it includes too many endpoints are measured within the same category. So you'll see like pain and eating in the same thing. And so they were concerned that if they give something else, like say, for example, you gave magic mouthwash and it included an antihistamine, so like Benadryl or something, and the Benadryl has a coating agent, you might be decreasing the pain and you can't control how much the patient self-administer. So you give them a bottle and they're going to use it differentially, and you can't quantify how much the patient's used. So you can't tell what was the effect of the additional agents. So the things that were not discluded were antifungals, because virtually everybody gets candidiasis and they need an antifungal agent. You could give magic mouthwash, but it couldn't have certain ingredients in it. It couldn't have Benadryl, for example. What we gave was viscous lidocaine, because that was not discluded from what you would give. So basically when you do a clinical trial, you're trying to control your signals so that you can compare what the effect of your intervention is. And that's why they had the discluded agents, but nothing was discluded. Like say, for example, somebody got a herpetic lesion, they would get their acyclovir or whatever that they needed to have. Same thing with the antifungals. But at that point, when the patients get to a 3, you're usually going systemic on giving those. So you're not hurting anybody by not giving a topical, because the candidiasis is too out of control and you're going to give it as a pill. Or the herpetic lesion, you're going to give that, you're going to give valcyclovir or whatever. You're going to give that systemically. You're not going to give it topically because it's not going to do that much good. So I would say, even though it seems like potentially confounding or unethical in the way it was done, I wouldn't classify it that way.
Okay, thank you. Does anyone else have a question?
Dr. Johnston.
Yes, Dr. Gordon, is cisplatin, the combination cisplatin and radiation, is this predominantly related to cisplatin alone, or other chemo has similar effects?
You mean like the side effects of chemo?
Yeah. Yes, ma'am.
Yeah, so actually, I'm sure Dennis can chime in on this. Cisplatin is the one that's primarily used, but when people have a contraindication like renal function, they'll move to carboplatin or another platin, but most of the platins have some of the same issues, but they're very effective as anti-tumor agents. They're just extremely toxic. Dennis, did you want to add?
So, yeah, so the ones that I've seen the biggest problems with in private practice were the cisplatin, and I saw it with carboplatin as well, but also 5-FU and Erbitux.
Yeah.
So.
Yeah, I mean, those agents cause a lot of mucositis. I mean, if you just gave cisplatin alone, and definitely if you give 5-FU alone, which frequently it is given alone, it causes a severe mucositis. But go ahead.
Combining those with the radiation is it even increases it further.
Yeah, but the reason they chose cisplatin is, again, it's a methodologic strategy. So they chose the agent that was most used, and you don't want to like have a whole bunch of agents because you'd have to stratify on agents, and then your sample size would go up astronomically. So they just figure that you'll extrapolate. So like if this gets approved, it'll say approved, for amelioration of oral mucositis when used with chemoradiation, and it may say cisplatin and whatever, but people will extrapolate to other chemotherapeutics. Dr. Wolf?
Yeah, I got here late, so I didn't hear everything that you had to say, but I didn't hear you mention how the drug was administered that you gave. I'm assuming it was given systemically?
Yes, it was given IV. So it's given IV slowly over an hour, and an hour prior to radiation therapy.
Okay, well, the thing that I was curious about is when you give something systemically, I thought that there was evidence that free radicals were cell signal mediators and things along those lines. And so I was curious if you had adverse effects, or you didn't mention any adverse effects. So you think some of that is nonsense, or any thoughts along those lines?
Yeah, actually, no, I don't think it's nonsense, because I'll tell you from my own observation, which of course I should never do. So when a study is designed, it reports on the endpoints that were, predetermined. But of course, for AEs or adverse effects, you report everything. In the preclinical animal studies, hypotension was an effect that was seen. And in these studies, we were actually one of the highest enrollers, so we probably saw the most subjects, but hypotension was an issue. And even though we were blinded, we detected hypotension. I couldn't tell, it didn't break the blind, because you don't know when somebody's laying down for an hour, and then they get up, you might have a orthostatic hypotension anyway, especially when you are hypovolemic. So as people lose more weight with their cancer therapy, they become more hypovolemic and they can't take in enough liquid and everything else. So they might still still might get hypotension, but that was one of the effects that we did see. So I wouldn't say it was devoid of side effects, but in terms of looking at side effects across all of them, it didn't distinguish itself. I agree with what you're saying in the pharmacologic and toxicologic world. If you don't see side effects, it usually means you really don't have an effect, which is one reason why you need the placebo group. I think the other thing is the number of side effects, or the side effects most reported, were due to the chemotherapeutic agents. And those are so severe that they overwhelm the other reports. So their frequency and everything else might obscure other issues, like say headache or something like that. So I wouldn't say that they were innocent and there was no effect, because there was clearly a dose response in the rodent studies with hypotension. And actually one of the exclusion criteria was anybody who was on a antihypertensive. So they were already excluded. So again, that's not the real world, right? Real world is going to be phase 4, when you actually have enough people receiving this without all the exclusion criteria, and you can see what's really going on.
I was curious, one other quick question was, if they're not getting the oral problems, oral mucositis, and you're not able to, I mean, and that's a treatment limiting step, is it not possible to zap them longer and harder and hopefully have a better outcome?
With radiation?
Yeah.
Yeah, well, what happens when you increase the fraction and the duration, you get much worse effects, you know, just to the mucosa. So they really try to minimize. So first of all, they fractionate. Secondly, they shield. And third, you really try to reduce the number of weeks. So they're trying to balance, you know, the radiation oncologists they're amazing the way they do this, but they try to walk the line with the imaging to the edge of toxicity, or they go toxicity, but to the edge of almost survivability that you can handle it, because they really want to kill the cancer.
But it seemed to me that you had greatly limited the severity there. And so that arguably would mean that there was, that you could ramp it up, because you still had people coming down with cancer a couple of years later. And my question was, if you hit them a little harder earlier and still maintain that safe zone, might you not be able to?
I see what you're saying. Yeah, I agree. So, I mean, if this becomes an approved agent, I wouldn't be surprised if they would try to take it further. So they would probably go further, like they would go 9 weeks if they could. That's what I've been told, but people can't handle it. So that's possible that you could like take your curative regimen further and people could withstand it, because you would be giving them something to beat back the most common side effect, which is mucositis. Dr. Sarcer?
Hi, great presentation. I just, it's a comment to Dr. Wolf. The safety of SOD mimetics are established in the 70s. And because their rate of processing superoxide is way less than indigenous SODs, it's like 10 to the 7, while indigenous SOD 10 to the 10 or 10 to the 12. So they are very safe. And actually, the lady who pioneered the scientist who pioneered these mimetics, actually, this year was honored with the Discovery Award from the Society of Redox Biology and Medicine. But also increasing the dose is not the right thing to do to kill cancer. It's not that easy, you know. Just well, if you kill 10 with 10 grays, let's give them 20 grays. Remember, the beam have to pass through a lot of normal tissue before it gets to the cancer. Increasing the dose will make way more, including inflammation and fibrosis. Radiation-induced fibrosis is a big problem. And what people trying here, like, you know, the group that you, Dr. Sharon, work with, I actually work with for at the University of Iowa. The basic science for those mimetics actually was done in the University of Iowa. I was part of the group, actually. I was within that group who developed the basic science for it. So increasing the dose is not, but now one thing about this study, they use IMRT, which is what they call intensely modulated radiation therapy. Now they're trying to use something called SBRT to try to have a better delivery of dose, where you actually target the actual cancer within. And it's a fancy software and a whole team. It's like a physicist and an engineer, a software, and then the radiation oncologist orchestrate all of that. So delivering a dose to a cancer become more complicated than
targeted delivery.
Yeah.
I agree. And so, I mean, there's definitely other approaches that they're using. Dennis, I saw your hand was up, and then you.
Yeah, it was just, you know, it was kind of adding to that. I think, you know, one of the things that I would think would be more worrisome with increased dose, say if you had a situation where you didn't have toxicity that was realized, are long-term side effects, neurotoxicity, other kinds of issues that are going to plague quality of life factors moving forward in the patient's life, permanent hyposalivation. I mean, those kinds of issues are very real and very complex for patients who were treated, let's say, prior to IMRT or any kind of guided, or any kind of deal where they were treated with conventional beam. These are very real problems for quality of life issues that complicate not only just physical well-being, but also mental well-being and the ability to handle other health challenges that come up in their lives.
Yeah, I agree with you. And I actually forgot to say that. So I'm so glad you said it, because the long-term effects of the radiation are pretty debilitating. So, permanent hyposalivation, trismus, and
Risk of osteonecrosis.
yeah, osteonecrosis, and then where you get stenosis, and I'm like blanking on this, but basically
Carotid and vascular issues as well.
yeah, and they can't open, so like permanent loss of
Trismus,
ability to
yeah.
open. Long-term issues with swallowing, lack of ability to swallow appropriately. These are like long-term issues from radiation that are super debilitating for patients. And so I agree. I don't think that necessarily just going longer on the radiation is like the best approach, and which is probably why they're trying to do the targets nowadays, or the Trojan horses and other types of things that they're trying to deliver more directly to the tumor.
I want to add one thing is the importance of using those. So the using of these mimetics have been like, was a dream 20 years ago, until a pharmaceutical company got behind it and everything. So it combined all what we look like, from basic science to translational science. That's that. And who actually developed this is a chemist. So you can see how all of that comes and culminate in such such a therapy that will help a lot of people. And actually they are thinking about it in the future. We are going to space. Let's be honest. We are going to space, and space is a radiation place. People for I think astronauts also who sit in space for a long time have a lot of dental hygiene and dental and mouth problem, like dryness and all of those. So these can be also some kind of preventive therapies or something like that. So this is fantastic. This is very important.
Thank you. Yeah, I think this is really important, and I'm looking forward to them getting approval. Any other questions or comments?
If not, I just want to say thank you everybody for being here today, and thank you again, Dr. Gordon, for your presentation.
Thank you. I see Dr. Wolf's hand up. I don't know if he
Yeah, I probably should have taken it back down, but I mean, among the things that was curious to me is how you hear all about antioxidants, and antioxidants in general don't work. And it seems to me that among the reasons they don't work is that your free radicals are generated by the mitochondria or whatever, and you need super high concentrations in the vicinity of where the things are actually being generated. So why do these work? Or, why do they work better?
Well, so that's the challenge, I think, when it was mentioned by Dr. Sarsour also. This is the challenge they're dealing with now. High dose, I mean, I've seen this happen with so many different drug development things. High dose IV to really saturate the vascular access into the tissue can work. If you're trying to do it orally, like, you say antioxidants don't work. Well, you can't take the large enough quantity necessarily, as you mentioned, in the face of a big insult to get enough. So what they're grappling with now is how they're going to deliver it. They would prefer not to have to do an IV over 60 minutes because that limits the ability to deliver it, which is a limitation of palifermin. It can only be infused. And so will they be able to administer it where it would be able to get to the target tissues at a sufficient concentration to make the difference? And I don't know that they can overcome that. So I think it works because it's a super high dose in the systemic circulation that goes into the mucosa well in advance of the insult, and it probably accumulates to some extent. So I think that's why it works, but I don't know if they can modify the route of administration.
So I can answer part of that when Dr. Wolf. So actually at the University of Iowa, they are developing ways to modify it to target the mitochondria. We were actually, successful in modifying a drug for malaria to be targeted more toward the mitochondria, and we showed that, published that already. So the one that Galera developed, actually, the basic science show they go to the mitochondria. There is many papers already being published on their effects and exactly where they go and within the cell and how their toxicity, all of that, done in vitro and then in animals and all of that. So if you want, I can ask the people to get those papers for you. But what I'm saying is that's because now we, it doesn't work because the way we are administering. Also, one of the success we're having is now we can actually target those to a different, on the subcellular level, not only to the cell we want to deliver. I can give you an example. The same group that worked with the University of Iowa, now they are using ascorbate, but they are not using your regular ascorbate because you have to eat half of the oranges in Florida to get that dose. It's pharmacological ascorbate that goes through the blood, intravenous, injected, and they're having great results with that. Either for normal tissue protection and sensitization of cancer to chemo and radiotherapy. So sometimes you have to just alter the chemical or the route or anything. So, but antioxidant work. The problem is the difficulty. Earlier it was not easy. People think I can eat something and prevent cancer and treat myself. It's not that easy.
And I will also mention that a lot of the patients that we see, at least, or we saw at our health center, they're not the most healthy people to start off with. So they don't have a great baseline of good diet, all that kind of stuff. They're probably already at risk because they're not nutritionally usually in good shape. Well, I'm really appreciative of the conversation, and I'm glad that people chimed in because it is Friday afternoon and I hate to be sitting here talking to myself. So thank you for your participation, and it's great to see everyone, and have a great weekend.
You too. Thanks
Bye-bye.
again.
We'll plug for Dr. Kennedy coming up. We look forward to her presentation.
Oh yeah.
Oh, I want to say something. We actually have now a radiation machine. If you are interested, do radiation experiments in the KC campus. So
For animals?
Has operation today.
Is it for animals or people?
It's for cells.
Oh, okay.
Animals we can do only cutaneous, but because we are limited to the power of the machine, so we cannot do really deep or whole body radiation, but we can do in vitro if anyone.
Good to know.
Okay.
Awesome.
All right.
Thank you. Thanks, everyone. Appreciate it.
Bye-bye.
Bye.